Welcome to our Corona webinar series, Anterior, Midpoint, Discluding Stops. So mess up your TMJ and why bother anyway with Don Malizia. It's going to be a real treat today because I know this is a topic that many people don't get exposed to. Anterior, Midpoint, Discluding Stops, what's that? I mean, I went for years without really understanding the importance of using this particular technique and the value it brought. It was both Don Malizia and Barry Glassman that brought this to my attention. So I'm thrilled to be able to bring this to you with them both here today. Don is going to be presenting, of course, but it's pretty well a joint collaborative effort. I'd like to take the opportunity to thank all of our sponsors. So grateful for their support for our programs, but in particular, as I always mention, the contribution they make to dental sleep medicine, the way they keep enhancing the products we use, enhancing the appliances based on our feedback, and enhancing the tools that we get to use in the field. They help us be able to do the job we do for our patients. So I'm so thankful for everything they do. Upcoming Corona webinars, we have the Snoozle, Novel Approach to Treatment of Snoring and Mild OSA. This is available in Canada, and pending FDA clearance, which should be happening shortly, will be available in the States later this year. So learn about it. Thursday, May the 21st, 1 p.m. Eastern Standard Time or Eastern Daylight Time. And we also have Dealing with COVID-19 at home and in the workplace. We have a family physician, trailblazing family physician, Dr. Elaine Chin, and speaking about various things, antigen testing for COVID-19, the Circle home sleep screening device, and many protocols and products that are available to help make both the workplace and the home safe. That's Thursday, May the 28th, and we're going to 7 p.m. because we realized by then probably there's going to be more people back at the office, and we wanted to make sure it was accessible. Of course, everything will be archived and available on sdacademy.com if you can't make it. Now, we also have Dental Sleep Medicine Speakeasy, our online meeting room, just like being there, except you're not. And it's a BYOB. Tomorrow's discussion will be on anterior, midpoint, discluding stops, or wherever else it might take us. So this happens between 3 and 5 on Wednesday afternoons, and it's been a lot of fun to date, so consider joining us. A little bit of housekeeping. Pick your audio option, phone or computer, and follow instructions. You can submit your questions here. If you want to make this panel go away, you just click on that little red arrow at the top, or you can put your hand up to get the attention of Elaine or one of the panelists. Your CE certificate will be emailed out within about 3 days. And for AGDCE, please remember to provide me both your dental license number and also your AGD number. Now, keep in mind, you really need to be on this for about an hour to get that CE for AGD, okay? So anterior, midpoint, discluding stops. So mess up your TMJ and why bother anyway? Our special guest, Dr. Don Malizia, runs a pain and sleep practice in Pennsylvania and has been in close collaboration with Barry Glassman for a long period of time. And I think you're going to really enjoy what Don has to share with us today. Go to it, Don.
Hi, folks. John, thank you for inviting me. So the big question in John's words, does the absence of posterior support to lead to TMJ problems? And I'm going to give you an emphatic no with a few exceptions. On the bottom right was a picture of a Somnomed. If I was going to deliver one, that's what it would look like. So our answer is no. These numbers come from a paper published by Morales in the late 80s. In an awake patient, they literally measured EMG forces as they moved the contact forward. So they started at first molars, worked their way around to the centrals, and by the time they got to the centrals, mass center activity reduced by half, anterior temporalis by 3/4. So by having that stop, what you see on the SomnoMed on the lower left of your screen, and keeping those posteriors apart, you reduce how hard the patient can clench. One of the advantages that I've had being with Barry as long as we have is we watched this progress from the early 2000s on. And I can remember the early TAP 1s and TAP 2s that were delivered with posterior stops because that's how Keith said to deliver them. And over the years, we watched our side effects and problems just decrease dramatically as we got away from that. I'm trying to, Barry, have you seen a posterior open bite since we got rid of posterior contact?
No, but your reference, Don, is interesting to Keith, because Keith was Panky trained, and as a result of being Panky trained, his original practice was pain management, and believed in posterior support, and consequently, when he made his TAP, it, by the nature of its anterior titrating assembly, it had anterior contact. So when he first evaluated, he looked and said, "Oh, we can't have that because we need posterior support." So he would put posterior support in it. And in my discussions with him, he said, there'd be times when I was doing it, I just didn't have the time, and I would leave the posterior support out, and found that it wasn't problematic at all. Nevertheless, his original protocol was to leave it in, and then keep adjusting it as you titrated it, and then when you got where you're, and then take it off so that you could titrate it, and go through the entire titration process without it, and then, even though you didn't have any pain or discomfort, when you got to where you're going, put it back in again, because in his mind, that's he needed it. It's only later on in the development he realized that we don't need it. But you're right. It's there was a definite change in we don't see the posterior open bites that we were seeing initially.
And initially, we used to see lower anteriors dumped, to use the ortho phrase, and we just don't see that anymore.
Right.
So, do you handle the poll question, John?
Yes, I'm going to be posting a poll question for everyone to answer. There we go. So if the attendees could please answer this question: have you ever utilized the anterior midpoint discluding stop feature to manage pain patients? So select one, either yes or no. And we'll close this up pretty quickly so that Don can continue. But it'd be interesting to know, of everybody that's on, what percentage of you are actually using this feature.
And when we're talking about pain, we're talking about specifically about joint pain, either joint in terms of arrangements, clicking, or pain of the joint. Ever used anterior midpoint stops for joint pain management of joint pain?
Okay, so we've had 100% answer, and the poll closed at 69% yes and 31% no.
It's the 69% on the list that I recognize. Just saying.
There we go.
Great.
Okay, so we can continue.
So that first paper, everything we do in dentistry today, we can point back to Costin. Costin was an ear, nose, and throat doc. And he looked at a sample of 12 patients who were either edentulous and fully edentulous in one arch or both arches. And he worked with a dentist by the name of Goodfriend, who was from the University of Pennsylvania, who was one of the first guys to do TMJ dissections. And they concluded that the loss of joint support from losing teeth led to all this pain. And these days, probably 4 to 6 times a year, we see a patient that has Costin syndrome. The patient is either fully edentulous or just one arch, doesn't wear their dentures at night when they sleep, and some small percentage of those patients will wind up in pain. So that's where all this posterior joint support need came from. It. Those are the words literally in that paper. Highlander was an anthropologist, and the photograph drawing will come up later, where he measured joint loads on a dry skull. So when we get to that picture, it'll become easier to see, but if you put a force directly under the chin and just measure forces, the forces are going to get greater the farther back you go. We'll show that it's different in a live person. It takes muscle contraction in order to create that force. Highlander's work got cemented into dental knowledge because he was quoted in oral anatomy textbooks. Green and Laskin in their books pretty much based a lot of their biomechanics on Highlander's work. So if you go into the history of dentistry looking at jaw function, this whole thing about posterior support is there from the beginning, in our mind, without a lot of good evidence. And here's the drawing that from Highlander's work. Side on the left, where the arrow is the contact around the premolars, the joint force is measured, and if you go to the other side, to the right side, where a splint is in place and contact is all on the molars, they show that the force is reduced the further back you go, which in reality, it's just the opposite. When you move the point of contact further forward, you're not getting the muscle contraction. The reflex control of mastication is actually run by posterior contact. So in order to get the masseter and the temporalis to contract, your back teeth have to touch. If they don't touch, they don't contract as hard. And Barry will show you EMGs later on that illustrate that. And this is the Morales paper that I referred to, that reduction in anterior temporalis activity can reach 75%. And we think that it's that sustained contraction of the temporalis that probably does the most force generation. The muscle fibers in the temporalis are extremely difficult to fatigue.
What's really interesting about that, Don, what's really interesting about that is that one of the biggest issues that we talk about a lot when we're teaching and when we're talking about sleep is to understand that sleep is a different neurophysiology than awake. We continue to try to look at awake parameters to predict sleep, to predict how appliances will function, etc. And we know we can't. We know that we can't. It's simply not an anatomical issue. It's a neurobiological issue, and as a result of that, looking at awake was very difficult to make that assumptions that what we're measuring and what we're seeing in awake patients is what we're measuring and seeing in sleeping patients. So many years ago, I was on staff at Sacred Heart Hospital here in Allentown, and we did a study where we looked at, I took the EMGs, knowing at that point that everything I had done showed that there's a reduction of 75% of the anterior temporalis and 50% of the masseter, but it was on awake patients. So now we go back to sleeping patients. And, they have EMGs for sleeping patients. It's just that for polysomnograms, it's just that they always put them on the anterior tibialis and the digastric. So I convinced our guys to take them and put them on anterior temporalis. And what we did was, before the patients went to bed, we put them on the anterior temporalis and had them clench their teeth, and then kept it on the anterior temporalis throughout the night and could watch the periods. Interestingly enough, when we were seeing interest on RMMAs, I had no idea at that point what we were looking at. It just wasn't clicking with us then. But the point is we looked at what maximum was attained in sleep. And while the numbers, interestingly, were higher, so the raw numbers are higher. I don't know about you, but I was taught in dental school, Don, were you taught, if I asked you how much harder can a patient clench at night than during the day, what would your answer be based on what you were taught in dental school. Do you remember?
No concept from dental school. That wasn't even mentioned.
Okay. Well, I had 8 times. Now I've got some really good friends. I see Larry's here from California, and I see Matt and Neil from England, and Rick is here, and Mark is here. So if you guys can chime in on with the chat, and if you agree with that, that's what you were taught. We were always taught there was significantly. I remember the term, the factor of 8. Maybe you remember less, maybe you remember more. I'd love to know what you were taught or what you remember as you recall. The point is that there was an increase by about but not 100% increase, by about 25% increase. So the patient that could clench 25% more at night than during the day. Having said that, the reduction was still the 75% from the maximum clenching ability during the day. So it was actually more at night, more than 75% of their maximum clenching at night. Does that make sense? That's probably the worst I ever explained it. But but in other words, if I looked at the raw numbers for night, if they could clench at 100 during the day, they can now clench. We would say, okay, now you can only clench at 25. What we found out is they could clench at 125 at night, but they were still only clenching at 25 at night. So it's actually more than 75% from their maximum clenching using their neurophysiology at night. I think that was a little better. I'm not sure.
And we have there's some unpublished data that shows that if you do place an anterior midpoint stop, you will see a gradual reduction on a night following night, and then when you take it away, it'll build back up again to where it was. So that was shown. Bad Hansen in 2007 did a study overnight and showed a reduction in EMG. Interestingly, though, the guys from Scandinavia agree that it reduces EMG, but their work didn't show a clinical difference. And if you place an old style maxillary NTI with monstrous vertical, that's what I would expect to have happen. 2011, Andy Blumenthal was the lead author, but Barry was involved. Published in Inside Dentistry, a big survey that was looking for how many side effects showed up with the usage of NTIs. And what was the number, Barry? Was it 6 or 9%? Was the number of people that reported difficulties out of those 5,000? So the whole issue.
1.5. 1.5%. Less than 2.
So the big concern that you'll hear from using an NTI is tooth movement and anterior open bite, and there are things to look for and ways to get beyond that with custom appliances. This isn't a pain course, but there's ways to handle those complaints. We've even gone to when there's a high risk of anterior open bite, we're starting to use AM aligners in the morning, even with B-splints. To see how that goes, and it looks promising at this point. Okay, John.
John Reisman now.
There's a concept in restorative dentistry called the shortened dental arch. The prosthodontists will argue in a patient without posterior teeth, how many do you have to replace to get the patient full function? And as a side effect, another outcome, they looked at the presence of temporomandibular disorders, particularly intra-articular, and no justification for replacing posterior missing molars or restoring missing posterior tooth contacts or prevent progression of TMJ internal derangement. So even long-term studies show that we don't need this posterior support. So when do you use it? I have placed, out of all the devices I've placed, my default appliance is a TAP 3 without posterior contact with thermocryl. That's 99% of the appliances I do on an everyday basis. So when do I use one? Almost every day. I have placed one TAP with a posterior contact recently. Very unusual patient. very unusual facial surgery history. The hardest clencher I have ever seen. He destroyed a tap without posterior contact. So I actually have placed one device with posterior contact in the last 15 years. So when do you not, as John would say, when you're okay with increased muscle activity?
Well, that's actually Barry. I have to interject here. I'm driving in a car with Barry several years ago. We're in Florida, and I said, "So Barry, so when would you not use an anterior midpoint discluding stop?"
We're talking about sleep appliances. We're talking about
in a sleep appliance, right? And Barry, without missing a beat, looked at me and said, as he was driving, "Well, when you're okay with increasing masseter muscle activity by 50% and temporalis muscle activity by 75%, that's what I wouldn't use it." And with a very serious look on his face, and that sort of changed my whole thinking about looking into these things more seriously.
We need to get into something here that's very, very important, Don, and that is Don and I are on a rampage as much as we can be in getting something very important across to the people with whom we work, and that is that there is the concept of getting rid of the idea that there are direct relationships, that there is a direct relationship between the amount of force and the amount of damage in any one specific area, or or the amount of force, for example, the amount of force and pain in the joint. That you can have less force and have more pain, and more bruxism and less pain, and more bruxism and no pain. We understand this. A lot has to do with two different factors. One is force direction and magnitude, and the other is what we call the trigeminal signal, the signal back that affects centrally mediated pain, central sensitization, etc. So there are no simple, you can't look and make the generalizations that oftentimes we want to make. So Don just said something really interesting. He said, we use the anterior midpoint stop because we find that in general, we're going to wind up with less force in the system and less pain. Also, less force in the system, so it's less likely to do damage. But where is most of this force likely to occur? In some cases, this force is likely to occur at that titration assembly, where in this particular instance, with this particular patient, he was destroying the assembly. So Don then goes ahead and adds posterior contact, and one might say, wait a second, but that's going to increase the forces. Is it not going to increase the forces? The answer is yes. It's going to increase the forces, but it's going to alter the direction. And now we're not getting most of the forces, we're having more forces, but less forces where it was being destroyed. And if his adaptive capacity allows him to deal with those additional forces, then he's still not in pain or dysfunction, and he's not breaking his appliance.
That sort of comes into a discussion of phenotype. Phenotype is a word that comes from genetics, which is a fancy way of saying what kind of patient is in front of you. Probably the most important tool I use every day is a little who do they come from, Barry? Therabyte sells a little cardboard ruler. It's probably the most important tool I use. If you have your new patient, they're opening 50 millimeters, no history of headache, nothing hurts. You can put 2 hockey pucks in their mouth and it's not going to make any difference. You have the little old lady who's 85 years old, her opening is 35 millimeters, you suspect 2 bilateral close locks that are asymptomatic. That's the patient that I just like having a tap that I can get a very small vertical, I can keep the contact in the front, I can reduce the forces, and I'm not going to make anything worse. So there's probably not a lot of people that are doing only anterior contact devices like Barry did and I'm still doing, and most people have no problem. But when you think back at the cases you see on an everyday basis where you have had problems, I'd be willing to bet you would probably see less problem in that 15 to 20% of cases that if you didn't have the posterior contact and the forces were lower, and the signal was lower, which gets complicated in this discussion, the patients would be more comfortable.
Most often, if you've got a patient in a sleep appliance and you've got a full contact appliance, if that pain is in the left temporomandibular joint, advice, I go right to anterior midpoint stops. But if you don't want to do that, or your appliance doesn't allow you to do that, look at making adjustments on the contralateral side, because it's that contralateral side that's setting off the contralateral work of the lateral pterygoid, potentially putting strain on the lateral and medial collateral ligaments. Look at the contralateral side, and even if it looks like it's even, adjust it, make it uneven with less strain on the contralateral side. Okay, next.
I think you've covered this.
Yeah, exactly.
We have a comment from John Busis saying that he has not placed one without a bump for nearly 10 years. It's a no-brainer.
Yeah.
Yeah, well, so what John is actually saying is that those of us who don't have brains use this appliance. It's great. I appreciate it, John. It's all good. So let's talk about posterior support, and is it really support, or is it simply, as we talked about, increased forces? Next. So if we look at where does this concept come from, that if we put in an anterior midpoint stop, we're going to compress and distalize the condyle? And I am totally convinced that some of this concept comes from the fact that if you put an anterior stop on an articulator, what happens is the maxilla comes forward, and consequently the condyle on an articulator looks like it's been distalized. This is what Don was suggesting when Highlander and others did their work on in vitro, using a physics model based on physics and fulcrums. When you don't consider the anatomy and the physiology of the force vectors of the masseters and the anterior temporalis, that's where our what comes to mind. If there isn't anything in the world that doesn't describe the fact that articulators have nothing to do with how a jaw functions, how is it that we in dentistry have all these years accepted the fact that an articulator is the upper unit that moves? I just thought I'd mention that. It has nothing to do with mandibular function, nothing. And so this has aggravated that concept that we're going to lose posterior contact. Next. When we consider, that's that distalizing again, and just showing how that doesn't actually happen. If we actually look at the forces of the musculature, we'll get to that in a little better description in the next slide, in the next coming slides. Next. So this, and I happen to have tremendous, I don't hold back, so I will tell you this is Terry Tanaka's slide, and you can't have more respect for a human being than I have for him. It's not possible. At the same time, as great an anatomist as he is, and as great as a prosthodontist as he is, when he gives lectures, he teaches about the fact that dentists are going to get in trouble because they use these, and he uses the terms like they're all the same: anterior deprogrammers, anterior jigs, NTIs. I see Brad's here, probably quick split, right, Brad? I mean, they're all the same. They're all exactly the same. They all do the same, and they all put the stop in the front. And what's going to happen is, because you have lack of posterior support, and you can see the arrow, you're going to crush the joint. And many times I'll show it actually going back. At least he shows it crushing it this way. And it's as though because there's going to fulcrum, that mandible's going to the fulcrum. Now just think about it. It's a solid body. It's not going to fulcrum. You can't fulcrum. It can, it's not by itself, but we'll carry on. So this is what's being taught. And he actually teaches that if there are marks on that thing, then you better get it out. And our point is, if there are marks on that thing, you better leave them in. That's the whole point. Now, but we want to talk specifically now. Let's accept the fact that we don't need this posterior support now. Let's talk about sleep appliances next. Okay, so one of the myths that we're taught is that the first 20 millimeters is pure rotation, and then we translate. And that just isn't true. There was an earlier study done, I forget that it was 2006, I think, that we refer to.
About 4 or 5 of them, man.
Yeah, and then this one in 2009. No matter what, there is no pure rotation. When you think about it, when the mandible opens, all of the pressors, all of them have been demonstrated to contract, including the lateral pterygoid. Well, if the lateral pterygoid contracts, where its origin is in the lateral pterygoid plate of the sphenoid bone, and its insertion of the inferior head is down on the fovea of the mandible of the condylar, below the condylar head, it's got to bring the mandible forward. Now, this is upsetting to some people in restorative worlds who want to teach CR, because they need pure rotation so that they can put something between the teeth and get a bite accurately transformed onto an articulator and can be checked with a Vericheck, etc. No one said that you can't do that. That there's a reason that Dawson wanted to romance the mandible, which I don't think he would get away with that in the Me Too world, but he wanted to romance the mandible and hold that condyle in place. And you can force a pure translation, a pure rotation, but it's not part of the body's normal function. Keep in mind also, opening and closing are not mirror images. So there is some pure rotation in closing, but that's a whole nother story. Next. So if we look at a sleep appliance and we put that sleep appliance with an anterior contact only, now we look at the forces. The first arrow is a force vector of the masseter. Its origin on the inferior medial surface of the zygoma. That's insertion on the mandible. And we look at the force vector of the anterior temporalis, whose origin is of the anterior temporalis and insertion is on the coronoid process. And we add those force vectors, which have magnitude and direction. We would wind up with an arrow in between those two, pointing where? Pointing forward, not knocking the condyle back. So the force vectors during the parafunctional event will bring the mandible not up and back, but forward. Now, the next factor is really interesting. Next. Here is a patient with a deep bite. This is an example. We had over 50, 60 of these patients, more that we did because we were trying to make a point. At one point, we were taking corrected tomograms on all of our patients. So this was a patient with if I showed you the pictures of the teeth, which is amazing. You're attending a dental course and you haven't seen a picture of a tooth yet. So anyway, is everyone still alive and functioning? Anyone's palpitations? You're all going? You're good? Good. Here's the thing. This is a patient, you would look at that, and it turns out that he had severe, it's important here, he had severe dental deep bite. Severe, all right? Now, we were taught that deep bites were going to have the condyles up and back because, that's it's going to shove the condyles back, and it's totally irrelevant compared to, there's so many other factors: size of the mandible, size of the zygoma, size of the ascending ramus, the angle of the eminence. All these factors are negated because if we looked on an articulator and we put a deep bite, the damn piece of metal would go back into the fossa. Okay, not necessarily the case on our patients. This patient's got dental deep bite, so we put an appliance that was an anterior midpoint stop in him, and this is what we got. Next. Next, John. Okay. So I'm asking this patient to rest gently on an anterior midpoint stop. Now, I have a question. Look at those condyles. By the way, those are where you're putting most of your condyles if you're going just 1 or 2 millimeters from a comfortable centric in your sleep appliance. Fascinating, right? Fascinating. Remember how we used to fight over where the best condylar posture is supposed to be? I mean, if Dawson and Gail, God bless Pete, but if I've often said that I studied with both of them. If both of them sat in the same room at age 78, only one of them would have come out alive, and they were both talking about the joint position as it turned out to be rather similar, but still didn't make any sense. Getting back to the point, if this patient's simply resting on their condyle or resting on their sleep appliance, on their anterior midpoint stop appliance, why is the condyle so far translated? They're not, that a sleep appliance doesn't have them open more than 20 millimeters. So why are they this far translated? They're this far translated because they are in a deep bite, so there is more translation and there is more opening than there normally would be, nowhere near 20. But at the same time, there's immediate translation, right? Now he's resting comfortably on that appliance. Now, if I told that patient, does that patient have posterior support at this moment? No, right? Is it wide open? Wide open. Great. Now I tell that patient, I want you to clench on your appliance. So imagine that. Oh, John, go back. It's too soon. Imagine, no matter how I train him. Imagine, if you will, that this patient's in a tap or any appliance with an anterior midpoint stop appliance, right? And now you tell that patient in their appliance, what I want you to do is to clench. And the tendency would be to say that in the absence of posterior support, you're going to crush that joint. You're going to crush the retrodiscal tissue, which didn't move, by the way. It's where it is, where it was. Now I tell that patient to clench as hard as they can. And John will show you what he already gave away.
Now?
Now. And we see this over and over and over again. It doesn't go anywhere. It doesn't go up and back. Why? One, because the force vectors that we just showed you are anteriorized. And it's not because the lack of support posterior support only did one thing, and what was it? Prevented the force vectors from being excessive potentially. Decreased the force vectors. That's all it does. That's all it does. When we put sleep appliances into patients, there is nothing that's straining the joint. Holding the jaw out, we're not asking the muscles to hold the jaw out. Why not? The appliances. So where is the strain on the joint? If a joint gets sprained or strained, how did it happen? It's probably happened during parafunction. And we're going to have less parafunctional forces with an anterior midpoint stop. Next. So here we're having a patient with their AMGs. They're just looking at temporalis, and there's the elevators and the depressors, and this is during function. We're looking at the patient chewing gum, and we're going to get 25, 30 microvolts of EMG activity, which is force in the system during function. That's all this part of the about 30 microvolts. All that this EMG shows. So I'm looking at force in the system. So now let's look at, this is kind of interesting. Clenching, EMG, looking at clenching without an anterior midpoint stop appliance. This is really interesting. I don't know if we can't stop this, can we, John? So she's just resting now. She's just resting. And now I'm having her close slightly and see if it stops. Can we stop that, John? Is that possible? Right there? Okay. To your far left, all the muscles were in rest. I was asking that patient to close slowly. While I'm asking that patient to close slowly, you think you would be asking you're asking the elevators to contract. You would think you would see more muscle activity. Fascinating, you don't. Why don't you see muscle activity when you're asking the patient to close? Because there's no resistance. There's no you're asking the mandible to be lifted up against gravity. The masseter temporalis can do that easily. Now they close and the teeth come gently together. And when the teeth come gently together and hit a specific threshold, I have no idea, Don, we have no idea what causes it, whether we're talking proprioceptors, mechanoreceptors. We're not sure where the message comes with posterior contact, but you see the muscles suddenly, like not gradually, suddenly take off. They suddenly take off. In this case, they took off, and when she brought her teeth together, she kind of panicked. And she thought, no, maybe I'm not supposed to bring my teeth together. So she opened again. And you see the muscles suddenly, all of a sudden, stop contracting. And I said, no, close. And as soon as she closed, boom, the muscles took off again. There must be posterior contact for this excess of force to take place. Not putting posterior contact in our sleep appliances prevents the excessive forces. I don't know that that's not fair. That's not accurate. Not putting posterior contact decreases the forces that exist. And it's possible in some cases we'll get them below what is required for their adaptive capacity. Next. So here's a patient on the left clenching on their teeth and now clenching on an anterior midpoint stop appliance. Next. And again, and we see this over and over and over again. That's what we see. It's almost without fail. Rarely we see it. There are patients that this doesn't happen on. It's really rare. Next. I mean, sometimes it's that extreme. Next. That's one with and without. Next. Some of this literature and a lot more, if you're interested, can be found if you copy this. I'll give you a minute to get this down. If you copy this, this is a site that has lots of information. For those that are interested and want to look at some of the injection techniques, the cenopathine ganglion or the ligament insertion, all those injections are on this site. It is organized, and if you look into advanced pain and sleep, under that you will find anterior midpoint stop, AMPS. All the literature that Don referred to, I don't know if Costin's in there. I'll get it in within the next, after we hang up. But most of the literature is in, and more. I know that Brad Hansen is in, and I know that the rotation studies are in, and I know that Hasegawa, for example, is in. Hasegawa study was interesting. How much time do we have? Hasegawa study was interesting because Hasegawa demonstrated that without posterior contact, the increased cerebral blood flow that we see, the same that we see in REM, the same that we see in migraine headaches, doesn't occur. And that with the posterior contact during bruxism, that sympathetic thrust, we also get this increased cerebral blood flow, which is fascinating. So does everybody have that? Can we move on? Great. So you can put these on most every appliance. That is an old Somnomed that I did many years ago. There was a point when I was teaching for Somnomed that they were calling that the Glassman ramp. I don't know what they call it now. They certainly after they fired me aren't going to call it that. But I suspect that there's a, you can just tell them that you want an anterior ramp. I'm sure that they'll get that. It's not that I invented the concept, for God's sakes. I didn't invent anything. But you can put it in that. We really like our go-to appliance is the tap for many reasons. I personally think that it's a kind of important that that the mandible, especially in specific cases, that the mandible not be allowed to drop. And just for security's sake, this is not to say that dorsals can't function. Of course they can, but there are lots of reasons we like tap, and we love the thermocryl, and we do everything we can to avoid posterior contact. There is an issue that some will raise, and Don, you want to address the anterior contact issue as far as periodontal health?
You'll hear, John has some cautions down below. That if you have mobile lower anteriors, you shouldn't be doing a sleep appliance in the first place if you go by pure periodontal parameters. I can tell you that that's never been a problem. A tap, particularly with thermocryl, splints those teeth together just like the periodontist would do to prevent the forces. So it hasn't been a problem. I can tell you that it was a problem with a tap with posterior contact. We would see dumped, to use the orthodontic term, dumped lower anteriors a lot. An interesting way to look at this is as an orthodontist and principles of anchorage and having teeth move when you don't want them to move. But John and I were having this discussion in this day of COVID-19 when we're trying to reduce office visits. A tap with thermocryl that allows the patient to adjust on their own, that you don't need to adjust the posterior every time things are moved, with a thermocryl lining that is custom developed at the chair, probably requires the least amount of adjustment on the doc's part of any other device you can possibly use. So
Don, just to interject, a tap without posterior support. That's important because some folks out there are putting posterior support in. Yeah, everything you just said, including a tap with no posterior support.
There is another factor. Go ahead, Doug.
But I just want to amend that to a tap 3. I know there are people whose labs are telling them that they can only get dream taps. I don't know why Airway tells them that, but Airway is still producing the tap 3 hardware, and Barry will have something new down the road that'll be even better. But just the force, something about the dream tap putting that contact further forward changes things. I've had more breakage, hook breaks, wire breaks with a dream tap that I've never had with the tap 3. So I'll amend that to a tap 3 without posterior contact and a thermocryl lining is now my go-to device.
Don made reference to an appliance that's made in England that we're bringing. We're in our steps for the FDA approval, and it's very much tap 3 like, except it has 9 millimeters of protrusive ability right from the get-go, and some of the design features that I really wanted out of the tap, and I tried to work with Airway to get them to do that, and they were never, it's just what I wanted. So there's no reason for them to be consistent about it. We will be consistent about it with a smaller profile and etc. So it's called a Morpheus, and it should be. We're hoping in about 3 to 4 months. We should have it available and ready to go. I'm very excited about it because it really has some potential in terms of, especially with the emphasis going away from the tap 3 and into the dream tap. The work with the dream tap is theoretical in terms of I want to get the titration assembly out of the way to create more tongue room, and yet we still haven't seen any evidence of good work. And it's not like Keith, because so much of the work is really well done from Hokima and elsewhere in terms of the effectiveness of the tap. But I have my own theories as to why they needed to switch and go to a dream tap, but that's a whole another issue. One of the issues important when you're dealing with anterior midpoint stop appliances is that there is this feeling. It's kind of interesting. There were many. I see. Is Ken still here? Ken Grunset was here. Ken Grunset will tell you this. Ken Grunset was in my office many years ago when we spent a week with Ken and Don. Were you there with Ken and Whit? No, you weren't there. I don't think.
No, that was after.
Yeah. So Ken and Whit are in the office, and Whit is 100. Wilkerson is 100% sure that these anterior midpoint stops are going to cause tenderness and tightness of the temporomandibular joint because that's the without posterior support. And Ken and Whit were working together as a team, and Ken put his appliance into Whit for Whit, and Whit squeezed his teeth and said right away, felt, oh my God, and it was tender in the temporomandibular joints. So Ken checked the appliance, and he realized that the discluding element was angled and was not in the long axis of the tooth. He made literally a 3-second adjustment and put it in, and you should have seen Whit's eyes. Oh my God, it doesn't. I don't feel that now. So making sure that it's more important in a pain situation than when you're dealing with a full arch or a partial arch appliance for sleep. It's pretty hard to screw up on a sleep appliance, but on a pain patient, it's very, very important that the forces be in the long axis of the tooth and that it's not geared. There's a tendency to think if it's going like this, it's going to drive the condyle back if your angle's like that. The forces are created by the muscles, not by this acrylic, but the acrylic can guide the muscles to create that posteriorization. So you want to make sure that you are in the long axis of the tooth. Next.
So we have another polling question.
The next polling question will be, should we have polling questions in the future? Okay.
Do you have a default oral sleep appliance, and which one? It only allowed me this many categories, so I'm sorry if I'm missing some of the less common categories. But anyway, I don't have a default oral sleep appliance, or ML-like, herps-like, dorsal-like, or tap-like. So go ahead and start voting, please. I don't see any voting going on. Barry, do you see a poll up on the screen?
Yes.
Okay.
You didn't get any votes?
Well, I don't think it's working. Do you see something, Elaine?
Yes, it's up, but there's
Yeah,
no
voting. So I'm just wondering why. So let me just see here. You know, this. Let me just try something a little different. Launch poll. Okay. So here we go. I think there was a dummy question in there that got launched instead. So this one here, you should be able to vote on. There we go.
I see that Brad's got his hand up. Did that get addressed? Brad and Mark?
John Busu says that he can't select anything and that there's nowhere to vote.
Right. That was our first attempt failed, but yeah, now we're fine. I'm good. We got 60% voted, so like I'm going to close this down about 5, pick something, And so we can move on and get back at the information. So closing it down in 5, 4, 3, 2,
Thanks, Mark.
1.
Thank you.
Okay, so share results. There we go. So 36% don't have a default oral sleep appliance. 7% Amylite, 21% herps, 11% dorsal, 25% tap.
I would expect that. Yeah, I would expect that. That's great.
Yeah.
That's great. That's a whole conversation for another day.
Right. Okay.
Let's go on. Is there anything else?
I believe there's basically discussion about the fact that you can add these anterior ramps on pretty well every device out there. You just have to reach out to the lab that you use, and I think making sure that you maintain the force, if you will, along the long axis of that bottom tooth is important. As Barry was saying.
And also in a dorsal, it's really important that you don't have it so that if you just picture this, if that mandible comes further out in protrusive, remember you're not control. If that mandible comes further out in protrusive, you do not want to get caught behind the discluding element.
Yeah.
You will create pain. So and remember that a mandible may come further out in sleep than they do for you in the chair. So you want an extra millimeter. So when you have that patient protrude, number one, if you've got that discluding element in place, you have that patient protrude, the first thing you want to check is posterior opening. You should not have increased opening in protrusive than you have in your rest position with closed. How do you have a rest position with closed? In your natural position with closed. So when you have the patient closed and they come forward, the angle shouldn't be that it's increasing the vertical dimension during a contraction while in protrusion. That's number one. Number two is that end of that of the discluding element, you should have another millimeter of clearance behind it, so that if it goes further, you're another millimeter, you are protected and not going to get caught behind it. So you don't want it to be too long because you don't want it to disturb the lip, etc. But it's got to be long enough. Now, usually it doesn't have to be very long at all because there's, how far can you don't have that much protrusion available, and you're already anteriorized. So you already you already come 2-3 millimeters forward from quote unquote rest or eccentric. So you don't have that far to protect, but you want to make sure you protect. When you're putting that tap in below, you want to make sure when that patient goes to left or right, they can squeeze, they can't have contact. And one of the things you're going to ask those patients is when they go far left, squeeze your teeth together. And when you're going to ask them, does that cause any tenderness or tightness? See, I learned something from Dawson. Any tenderness or tightness in anywhere. And the only thing you care about is the contralateral joint. If they say, oh, it's a little discomforting, you went left and it hurts them in the right joint, you've got to decrease the vertical. You've got to decrease the vertical. Now in a tap, you can decrease the vertical. It gets a little, you can by altering the placement of the bars, etc. And you can actually change the position of the titration assembly. And we teach people to do that in our courses, but you've got to be able to at least consider that. So we are thinking, in general, we like to keep, especially in patients with joint problems, we're thinking minimize the vertical as much as we can. The exception, of course, is in males with large tongues, where we might think that we might need a little bit more vertical for them there. Okay. Anything else,
I've
John?
also added discluding elements to Herbst appliances and just made my life so much easier adjusting them. Interestingly, Herbst probably has some of the best evidence base for cardiovascular outcomes out of any other appliance that was studied. So out of an abundance of caution, if I have a patient with severe cardiac issues, I actually will place a HERS just for, because that's where the evidence points, with an anterior contact that just makes it so much easier to adjust and for the patient to deal with.
Okay.
Okay, so let me jump in here for a second. It's 2 o'clock, and we've used all our time up for the presentation. However, there will be question and answer. For those that have another obligation to go to and can't stick around, it's not a problem. You'll get your CE credit, but make sure you leave me your HED point number and your dental number as you're exiting if you didn't do so on entry. And for those that want to stick around and ask questions, we'll be here for as long as you want to field those questions going forward. And for those that have to leave, thank you so much for joining us.
Thank you. All good.
Thank you, everyone.
Okay, so Elaine, can you field some questions for us?
Yeah, I have a question from Brad. Can you hear me?
Yep.
I have a question from Brad Eli. In general, can we really predetermine or pre-treat ID a person who is going to have a problem? Or is it our experience that treatment is started, then we adjust those whom have a problem?
So am I hearing that as do you have to start without posterior contact, or can you take it away later if there is a problem? Is that the question?
Brad?
Elaine, read it once again, please. Yeah.
In general, can we really pre-treat ID a person who is going to have a problem?
Okay. So the answer, listen, I'm not sure where Brad's going with this. So let me try. And Brad, tell us if I know you have a point you're making. So I don't know if it's pre-treat. So the answer is, let's say we've got a patient that comes to us and we truly believe, and there's really good literature, that TM joint problems are exaggerated in terms of fear mongering when it comes to sleep appliances, and that they don't cause the number of problems that they cause. Two, that the problems aren't as severe as as people think they are. And one of the reasons they think they're severe is oftentimes they can be extreme, but the degree of pain has nothing to do with the degree of severity. And oftentimes we think it's most upsetting because if we're not used to treating joint pain or problems, now it seems worse because what scares us most is that which we don't understand. So if a patient comes to us and we've got in our head that this can make their situation worse, and they've already got a click or history of joint pain, the tendency might be to say, you're not a candidate, when in fact, they should be a candidate. And the only real fear is your own. So what I'm getting at is, if Brad's question is about pre-treating, yes, there are times that we will see a patient and they've got some joint issues that are major or minor or whatever, that we can start with an anterior midpoint stop kind of appliance therapy while we're proceeding, and they've already improved the situation prior to putting them in their sleep appliance, which will only make their situation continue to improve. So that's the first issue. The second is, can we predict who's going to have the problems? And the answer is, yeah, if we could look at the phenotypes, that would be great, and I think in time we will be able to. But right now, it's just not that simple to predict. And you can't look at deep bite and say, well, that patient's going to have a problem, or a history of a joint problem. Well, that patient's likely to have a problem. It's very, very tough. I would suggest, Don, and please chime in and disagree if I'm wrong. I would suggest that it's really, really tough to predict the potential problems associated with a sleep appliance.
I'd say I have rules of thumb that I follow. I have a patient bite on, I'll stack up 4 to 6 tongue depressors, have them bite on their anterior, see if I can cause any pain from that. I'll have them protrude further, see if I can cause pain. If I am causing pain, I'll put the stacks of tongue blades between their posterior teeth and close. So I've had patients that I have said, you need to try CPAP first because you are not a good candidate because you do come with this quote unquote TND condition from the beginning. So that does happen on occasion.
I can't say it's ever happened. I've never done that.
Brad just wrote a comment. Exactly, no predictive.
Right. Okay.
Thank you, Brad.
Yeah, and that's why we like anterior midpoint stops on on everybody, and it goes back to that question: when would you not use an anterior midpoint stop? And then I would not use it when I would use it, not use it when I wanted to increase the forces. That's more forces.
So he says, so can we stop making it seem so difficult so that acceptance can improve with the referral?
Yeah, our Brad, I don't have to tell you this. Our problem is everything's been made more difficult. Temporomandibular joint issues are made more difficult. Appliance designs made more difficult. I love John Coyce and Spear and Pankey, and all they do is, but honestly, when it comes to pain or dysfunction, they combine their dental logic with their pain logic, and they make it more difficult. And then they make the restorative care more difficult out of concern for their pain or dysfunction concepts. None of it's that difficult. So the problem is the dental myths that exist that people believe in, that we fight all the time. And what we know is the following: learning is easy, unlearning is difficult. And it's very tough to take a dentist who knows what they know from confirmation bias and make them believe. And so the vast majority of dentists look at an NTI or any anterior midpoint stop appliance and talk about I'm going to intrude the mandibular anterior teeth, even though House's studies show that that's not possible. I'm going to have posterior eruption because I've seen posterior eruption when they don't understand that it has a lot to do with lack of functionality and change in the trabecular structure that leads to the super eruption. I'm going to destroy the anterior teeth. I'm taking all the forces and putting them on the anterior teeth. I'm going to hurt the anterior teeth. I'm going to crush the joints because I don't have posterior support. You can't.
Great.
You can't.
So that, sorry, they're coming furious now. The comments. So Brad says, loved you and Don's article in DT. It's a great start. Now we have a comment here from Lawrence Jones. There's school of thought that says it is absolutely necessary to cover all posterior teeth in a sleep appliance to avoid over eruption.
Yeah.
Anybody want to comment on that?
And there you go. I mean, or that you need to wrap the second molar to prevent open contacts. You can wrap the second molars and get open contacts. I don't know how to tell you that. It's how does it happen? I don't know. I can't answer that. I don't know.
I have seen photographs of one case. Happened to be a dentist whose second molars erupted when he took himself out of contact. So I just haven't seen it.
One of the nice things about a tap apply, think about this. One of the biggest complaints that people have is that it's bulky and it's gag reflex. We'll make contact. We'll go bicuspid to bicuspid, upper and lower. Canine to canine I've done. Upper and lower.
John, can you go back to that slide that has the thermocryl tap, just to go over the low profile? It was the last one. So on the upper, you can see how short that is. We can't see the lower. But I've had cases where I've literally cut it off halfway back in a gagger on the lower. I've got patients with canine to canine on the lower that are doing just fine. So that's the nice thing about the thermocryl. If you have to shorten it up, you can get the retention that you need. So in a gagger, this is an ideal device that can be shortened up, and you can just give the tongue all the space it wants.
You're missing a first molar, and you've got a second molar and a second bi. Why would you ever go to the second molar? You know, just go to the bicuspid. Why would you ever fill that empty space? There are, keep this in mind. Every appliance has two different pieces to it. One is the vehicle. The other is the active ingredient. The vehicle keeps it on the teeth. Dentistry fights about the vehicle all the time. The active ingredient is what causes the force or creates the appliance mechanism. In a sleep appliance, the active ingredient is that assembly which is being titrated to hold the mandible forward. The vehicle holds it on the teeth. Now, if you assume that the vehicle has to cover all the teeth to prevent some kind of problem, then the vehicle becomes part of that active ingredient. Well, unfortunately, it's just not the case. It just isn't the case, and in the vast majority of cases. So we have, it's our go-to, and without any difficulty. Any other questions?
And just one more thing on the posterior eruption. Paper published in Orthodontics by Kinoshito a long time ago that said you need 10 hours with no force to get an eruption. And the question that I've heard, I think I heard it from Boyd first, when somebody says, you know, go find an orthodontist and tell him you want to extrude the molars, but the patient can only wear the device for 6 to 8 hours a day. And they'll tell you
And you
it's
can't
impossible.
put that, wait a second. And I want you to extrude the molars. But I want super eruption in the second molars, but here are the rules. One, you can wear an appliance. You can only wear the appliance at night, and the appliance can't touch the teeth you want to super erupt. And the orthodontist looks at you and says, "That's crazy. You can't do it." And I tell them, "Well, that's amazing. I'm clearly better than you because everybody tells me I'm doing that."
And it looks like there's a question, does it matter if the stop is placed on the upper or lower? In a sleep appliance, you don't get enough lateral motion for it to be a problem. If you're treating pain, it's a whole other thing. The default position is on the lower so that you avoid canine contact, but that's for a discussion for another day. So short answer, isn't as critical in a sleep appliance.
Anything else?
That's it for the questions.
That's it. Good.
That's it for the questions. Okay, so let's thank you very much, guys. I really appreciate everyone's efforts. A heartfelt thank you to all the medical personnel, of course, and everyone else on the front lines making the world happen while we're at home trying to flatten the curve. Little reminder about our 2 upcoming webinars. The Schnoozil, basically tensing of the tongue muscle to make it stronger and help with mild sleep apnea and snoring, and perhaps adjunctively with more severe sleep apnea. Dealing with COVID-19 at home, on Thursday, May 28th. All sorts of COVID tips from a family physician that's really heavily involved and very trailblazing in her practice and the things she's involved in, the products that she's involved in, including antigen testing for COVID. And so thanks very much for joining us. I appreciate everyone's efforts. It's 2:14. Thanks for sticking around, and see you at the next webinar.
Thanks, everyone.